Okay, so last but not least, so for those Rapp, my old friend, and he actually completed a fellowship also in UMS, and in 1989, sounds like a while ago, and he has been practicing in ARDC until recently retired and moved back to Philadelphia. And we really appreciate it. He actually traveled here just to give the talk. Okay, so, and he made the version, like 10 versions. I already downloaded as my future reference. So that's actually, it's a long talk, but very important. That's all covered. And then, over the years, he actually knows, I can say, know more kind of lipids than anybody in Arkansas or, certain part of the United States. Thank you.
I didn't think he was talking about me when he made this. Somebody just said to me that they have difficulty with dyslipidemia and understanding lipids. And I'll just tell you what my organic professor taught me when I was at Columbia taking an organic final. And he said, if your body can do organic chemistry, how come your mind can't? So that was my starting point. So basically, my title is American College of Cardiology, AHA Guidelines for Non-Statin Pathways. It's very tricky. And so let me give you a brief overview. I'm going to talk about background because the seminal studies that were made basically then go into the documentation to write out algorithms. And it's important to have some notion about what data led to those conclusions. I'll talk about recent outcomes trials, that's the bempedoic acid trials that came out after the non-statin pathway came out for primary prevention and secondary intervention, a brief overview of ACC/AHA guidelines, and then useful stuff, toolboxes, how drugs affecting LDL cholesterol metabolism work, and I'll probably fly through that, but you can use that as a desktop reference because it's pretty comprehensive. And then the meat of the matter is the ACC/AHA non-statin pathways, and we'll talk about 9 clinical lipid scenarios with a lot of similarities, and hopefully we'll get the gist of that and we feel comfortable with that. And then the algorithm for statin intolerant patients and conclusions, and then the end will be near. So this is one of the first trials that came out in 2010. It's called the Cholesterol Treatment Trialist. It's a trial of 27 randomized clinical trials. 21 were statins versus placebo, and 6 were high statins versus weak statins. They weren't always high intensity versus low intensity. And basically they came out with a very interesting conclusion. They asked the question, a 1 millimole per liter drop in LDL cholesterol per year, what would that impact be in terms of the hazard ratio? Would there be a reduction, and what number would that be? And it turned out for MACE, that's major adverse cardiovascular events, the hazard ratio of 0.78 would produce a 22% reduction in LDL cholesterol. And this is over a wide range of LDL cholesterol values. Now, if the drop in LDL cholesterol were 2 millimoles per liter, well, then it would be the hazard ratio of 0.78 squared, and I did have a calculator to do this, to verify this, and the hazard ratio would be 0.61, so now the MACE would drop by 40%. So basically, the more you drop, the greater the benefit for 1 millimole, 2 millimoles, or 3 millimoles. And that is independent of the baseline LDL cholesterol, which is an important point. Interestingly enough, a 1 millimole per liter drop, or 38.6 milligrams per deciliter drop in LDL per year, lowered vascular mortality by 15% in primary prevention patients. In other words, patients that did not have a prior history of vascular disease. And again, these relationships hold even at low baseline LDL. So this was published in 2010. So this is another way of looking at the same data. And basically, they looked at increments of 40, so for LDL cholesterol 90 to 130, that's 40 milligrams per deciliter, which is close to 38.6 milligrams per deciliter, and 50 to 90 milligrams per deciliter, close to 38.6. For those 40 milligram per deciliter spreads, the reduction in LDL cholesterol was the same, but more importantly, the hazard ratio was the same. And so regardless of the baseline LDL, for points from 77 down to 136, all those confidence intervals, first of all, they don't cross the line of scrimmage. We are in Arkansas, after all. And so those confidence intervals are all overlapping, suggesting there's no difference in the change for all those starting points at baseline LDL. So a 1 millimole per liter drop lowers LDL by 22%, period, end of story. Okay, the next question you could ask is, what is the impact, and this was again from the Brits, the cholesterol treatment trials plan. This is 134,000 patients in 27 randomized clinical trials. Does the baseline cardiovascular risk category, in other words, on high risk or low risk, will that impact on that relationship between 1 millimole per liter drop in LDL cholesterol? Did it or did it not? So basically, the risk, and the Brits used a 5-year risk score. We typically use a 10-year risk score. So the low end of the risk was less than 5%, and arguably we could say less than 10% for the risk score. On the low end, and on the high end was greater than 30%. The major vascular events were CHD, death, non-fatal MI, or CHD death, stroke, and coronary revascularizations. I'm going to try to use the... So this is the proportional reduction in the two lowest categories of 5-year risk. And you would think the risk would not be that much reduced because the baseline risk was low. So it's less than 10%, a 1 millimole per liter LDL cholesterol reduction, hazard ratio 0.62, or 38% reduction in risk. What about the high-risk people that have greater than 30% risk for 5 years? The hazard ratio per 1 millimole reduction in LDL cholesterol was 0.79. So that's 21%. So actually, people that were in the low-risk group had more benefit than people in the high risk. And I've always felt that the distinction between primary prevention, meaning I have no events in the past, and secondary intervention is somewhat spurious. There's a lot of overlap, and I think this trial does address it. Now, we could critique this because in the States we look at 10-year risks rather than 5-year risks, and it's possible that that was not enough. Again, just to make the point again, in patients that have no history of vascular disease, a 15% reduction in vascular mortality for a 1 millimole per liter reduction in LDL cholesterol. And it's in the primary prevention mode. And all-cause mortality was reduced by 9% because the hazard ratio was 0.91. So this basically says baseline cardiovascular risk may not tell you the whole story. I don't think that's a complete and accurate conclusion, but it is certainly something that's reasonable coming out of this trial. So we can now ask the question is, so most people will tell you they know nothing about cholesterol, they'll say lower is better, and they're right. They're absolutely right. So what is the evidence? This is a meta-analysis of 38,000 patients, and I think you all know what a meta-analysis is. It's just a study of studies, and you get large numbers of patients, so you can get more data and more accurate findings. This was 5 secondary intervention trials and 3 primary prevention trials. And what they did was they looked at the baseline, they looked at LDL cholesterol, non-HDL and ApoB. But for the purpose of simplicity, we're not going to worry about ApoB and non-HDL. We're just going to look at the LDL cholesterol level on the x-axis and the hazard ratio for major adverse cardiovascular events on the y-axis. And the question is there an on-trial LDL cholesterol in actual randomized clinical trials where the hazard ratio caps out? In other words, we get lower and lower and lower and lower LDL on trial, but we don't see any more benefit. Does that happen? And this was basically, this study came out in Journal of American College of Cardiology by Matej Bukov, and this is in 2014, well before the guidelines came out in 2018, and that's an interesting point of this presentation. So here we're looking at the x-axis, which is the on-trial LDL cholesterol. The y-axis is the hazard ratio. We're going to not follow the ApoB or the non-HDL. We're just going to make this simple. So we start with a hazard ratio of 1 for a high on-trial cholesterol greater than or equal to 175. And by the way, it's adjusted for sex, age, smoking, diabetes, systolic blood pressure, and HDL. So notice as the brown goes to a lower on-trial LDL, to a lower on-trial LDL. So you're getting the point that the hazard ratio keeps dropping as the LDL on trial goes down. But this is where we were in 2018. In 2018, the guidelines for ASCVD patients, for very high-risk patients, was that they should have an LDL less than 70 milligram per deciliter. They also made a distinction between very risk and high-risk patients, and for some strange reason, the LDL cholesterol goal for both groups was the same at less than 70. But the point of the slide is, here's the hazard ratio of 0.51. If we went down to a less than 50 milligram per deciliter, we would drop 7 percentage points and have greater impact. And this came out in 2014, and the guidelines came out in 2018, and I don't know why they stopped at 70. I really don't understand that. One other point that's important is when we look at LDL cholesterol thresholds, we're basically looking at LDL cholesterol. But we also look at non-HDL cholesterol, which typically is 30 points higher than LDL cholesterol. And that comes from triglycerides that are normal at 150 divided by 5. A VLDL particle has 5 parts triglyceride, 1 part cholesterol. So 150 divided by 5 is 30 if the triglycerides are normal. So basically, whenever we talk about non-HDL cholesterol, we're going to talk about a 30 milligram per deciliter uptick. Okay? So that's clear, and those are the trials. So now let's change gears and let's introduce bempedoic acid. Who has not heard of bempedoic acid? Your honesty is alarming and refreshing. Thank you very much. So let me introduce you to bempedoic acid. Bempedoic acid is a drug. It's actually not a drug, it's a prodrug, and it is used for lowering the cholesterol biosynthesis. Now, every cell in your human body makes cholesterol, and every cell in your body has LDL receptors. So, bempedoic acid blocks, and this is a mouthful, ATP citrate lyase, which is the first enzyme, the first step to form the first metabolite of cholesterol biosynthesis, which is acetyl-CoA. And so, bempedoic acid is particularly useful because nowadays statin intolerance is one of the professors at one of the universities said I'm intolerant of statin intolerant people, and I can certainly understand and sympathize. But bempedoic acid is a prodrug, which means it needs to be activated, and it's activated by an enzyme called very long-chain acyl-CoA. Now, that's a mouthful and it's trivia, but it's important because that enzyme is only found in the liver. So for those individuals that think that the reason there are myopathic complaints associated with statins is because the intracellular concentration of cholesterol in a muscle cell diminishes, and that has negative effects, it don't happen with this drug because it gets activated by a liver enzyme, not an enzyme in the muscle. And in fact, the phase 3 trials, the discontinuation rate between placebo and treated group was exactly the same. So this is really a good drug for statin-intolerant patients, and that's its niche. By the way, though it may not seem intuitively obvious, when I first found out about this drug and said, well, this drug is going to work on top of a statin background, statins block the rate-limiting step for the biosynthesis of cholesterol, HMG-CoA reductase. And so it would make very little sense to me that we could use another drug to block another enzyme when we already have the rate-limiting step and have further benefit. But in fact, I was wrong. The benefit is incremental on top of what a statin is used, and the drug is used effectively on a statin background, particularly in statin-intolerant patients. So the CLEAR Outcomes trial was a primary prevention trial, secondary intervention trial. It did a little bit of statistical chicanery. The population that they looked at was about 13,000 patients, of which 4,200 patients were for primary prevention, and the rest for secondary intervention. When you start pulling subgroups out, you do have the possibility that there may be confounders that you're not aware of that could make your results false. That didn't appear to be the case based upon the statistical significance of the endpoints that were defined. So let's go through. And by the way, this data was not reflected in the non-statin pathway because it came out afterwards. So let's go. So here is the primary prevention trial. My dying anemic pointer here. Okay, so patients were unwilling or unable to take statins. I'm sure you've all experienced that. Okay, but what really strikes me is this red and I tend to use red when something strikes me, unless my font is down, so I don't know. But when there were 66% of the people in this primary prevention trial with diabetes. Now, they were specifically looking for high-risk patients in the primary prevention group. Now, one can ask, if we did another study with primary prevention, but we had a heck of a lot less diabetics, would we see the same benefit? And that's a very legitimate question to ask. Now, that said, most of the patients were Caucasian. Mean age was 68. Now, the primary endpoint was something called MACE-4, Major Adverse Cardiovascular Events, and that was a fourfold endpoint: cardiovascular mortality, non-fatal MI, non-fatal stroke, and revascularization. So it didn't take a rocket scientist to say, well, MACE-3 is probably 3 events, and they dropped revascularization. Why did they drop revascularization? Because revascularization is very often discretionary. Some guy will do it, or I shouldn't say that. Some person will do it, another person may not. So basically, those were the 2 endpoints. The LDL was 142, which is high, but not dramatically high, but not, you would expect that for people that are not on statins. The HSCRP was 2.4 milligrams per liter. Statin use was not surprisingly low because of the statin intolerance, and ezetimibe was surprisingly low. You would think that would have been used in lieu of the statin, but it was not. And this is published in JAMA by Steve Vincent, who was a very vocal person, lipidologist. So now let's look at the LDL reduction for baseline. It was about 21%. This is placebo adjusted. So if the placebo group starts going up, the spread between the 2 groups goes up, and the percentage difference goes up. The HSCRP was 2.4 milligrams per liter, and the HSCRP dropped by 0.56, or about 22%. The primary endpoint, MACE-4, note the p-value is significant. The hazard ratio is 0.70, so 30% risk reduction in MACE-4. For MACE-3, the hazard ratio was 0.64, so a 36% reduction in MACE-3. But that's important news. But what is also very important that we tend to forget in clinical trials is what are the number needed to treat to prevent one event. And so here we do this. We just take the absolute ratio, absolute risk ratio, which is basically the placebo event rate minus the treated event rate, put that in the denominator, and then divide that out, and you get 43 patients to prevent one primary event. I will tell you that anything below 100 is good, anything below 50 is dynamite. So that shows that this was pretty darn effective. For the MACE-3, 42 to prevent one event. Interestingly, there was no benefit on stroke or coronary revascularization. And it's really hard. A lot of really good drugs just don't seem to affect stroke. Stroke is a very hard endpoint to improve. If we look at adverse events, gout 2.6% versus 2, it doesn't, not that striking, but if you look at hyperuricemia, it's 12.1% versus 6, that's double. So how does that come about? The reason is because bempedoic acid is excreted in the proximal tubule of the kidney, the organic anion transporter tube, and so is uric acid. So it's basically like both substances are trying to get out at the same time, and as a result, that causes uric acid to go up. When I use bempedoic acid, if the uric acid is baseline 6 milligrams per deciliter, I would use allopurinol to get it down before I would start the bempedoic acid. I will tell you, in the phase 3 trials, it was 11.7% in the treated group, and it was 1.7% in the placebo group. However, they stratified those patients based upon a prior history of gout or not. It was 1% in the treated group and 0.3% in the placebo group. So it really depends. If there is a primary history of gout, it's important to get that. And obviously, if there is, you might be more inclined to treat the uric acid, because you don't want to have a patient come back to you and say, your cholesterol is great, but my gout is killing me. So that's that. Liver enzymes, not an issue. Cholelithiasis, not an issue. Hyperuricemia, we've explained. And again, this is another validation. Noted that myalgias, or let's just call them myopathic symptoms, was lower in the bempedoic acid than in the placebo group, suggesting again that this drug's prodrug basis and activation by a non-muscle enzyme basically played some role in why it was so well tolerated. So these drugs are going to be very, very active for the use of statin-intolerant patients. So let's now go to the secondary intervention trial. And these were patients, now this was a population of 13 or 14,000 patients, of which 4,000 were primary prevention. This is about 9,800 that are secondary intervention patients. 45% had diabetes and 19% had poor control. And if I recall correctly, that meant an A1C above 9, which in some ways, many people's clinic would say not bad, but it was obviously not good control. By the way, bempedoic acid is given at 180 milligrams daily with or without food. It does not matter. Secondary interventions, that was a 70% left over after the primary prevention trial, a little higher than 50% for coronary disease. Interestingly, peripheral vascular disease is 11.4%. You don't see that as high in randomized clinical trials. It's really hard to see a benefit in PVD, and stroke was 14.7. The primary endpoint was MACE-4, and that is basically what we've discussed. The LDL was 139. I think you would all agree that an LDL 139 for a secondary intervention group is much too high. And so basically what the endpoint, the trial went on 60 months, so that's 5 years. So the LDL and hsCRP percentage drop, and these were placebo adjusted, for LDL dropped at 6 months at 21%, hsCRP at 22%, and at 60 months, which basically is a testament to how resilient the impact was on LDL and hsCRP, was 26%, and that's the reason. The reason for that is because the placebo group went up, and there's always creep, there's always failure. We use what's called intention to treat, and if you don't take the medicine, you're still reckoned in, and so the numbers get worse, and the spread between the two groups goes up. And hsCRP was 19%, which held on pretty well. MACE-4 was decreased by 13%, or the hazard ratio was 0.87. The number needed to treat a little higher than we saw in the primary prevention trial, but nonetheless very believable. MACE-3, hazard ratio 0.85, against significant p-values with 77 patients to prevent one event. Myocardial infarction, fatal or non-fatal MI, the hazard ratio is 0.77, or 23% risk reduction, which is pretty substantial. And coronary cardiovascular revascularization, hazard ratio is 0.81, significant p-value of 9%. No impact on stroke again, interestingly, and no impact on cardiovascular or all-cause mortality. The adverse effects we've kind of discussed, they were similar to what we saw in the primary prevention trial. So basically, both trials said the same thing, that this drug is effective, particularly in patients that are quote-unquote statin intolerant in both the primary and the secondary intervention modalities. So let's go back, and we're going back and forth in terms of time. In 2018, there was a revelation that was obvious maybe 4 or 5 years earlier. So the first guidelines came out in 2013, and there was no distinction made for ASCVD patients between very high risk and high risk patients. And that distinction should have been made, but was not. So in 2018, basically, the distinction was made between very high risk patients and high risk patients. And though they did make the distinction, and I'll go through what the criteria were in a second, the LDL goal, and it's really not a goal, the LDL threshold for both groups was the same. So I didn't understand the rationale of having one group that has very high risk, one that has less, but you're still trying to get to the same number in terms of LDL cholesterol. But nonetheless, that is the history. Okay, so this is, I guess the cardiologist would like the endocrinologist to memorize as much as possible. So this is the definition of a very high-risk patient. If you had an MI with less than a year of presentation, if you had a second MI, which is not equal to the first MI, if you had an ischemic stroke, and please be aware that an embolic stroke is not atherosclerotic. It is not, so it should not be counted. Peripheral vascular disease is rather stringently defined as an arterial bypass, FEMPOD, FEMTIB, or prior limb amputation, which could be a Symes amputation, aka BKM, or an ABI less than 0.9, that's the ankle brachial index. So you needed to have 2 of these, and I know this is not fascinating at all, but just so we have the same terminology, you needed to have 2 of these to be a very high-risk person. Alternatively, if you only had 1, then we would go to the high-risk elements. Those are my terms because I don't know what else to call them. So age greater than 65, diabetes, hypertension. PCI is a percutaneous coronary intervention, be it a bypass or a stent, but not done for these events. It had to be separate. Chronic renal failure, this is stage 3 renal failure, less than 60 milliliters per minute. And FH hypercholesterolemia. Now, I'm not going to go into the protocols, but I will mention, and you can look this up, the two clinical protocols that are typically used for the diagnosis of familial hypercholesterolemia heterozygote is called the Simon-Broome, B-R-O-O-N-E, and you can get that online. And the second is called the Dutch criteria. The Dutch criteria is more stringent and uses LDL cholesterol values as a number, and if your value is 8 points, you have FH. Obviously, you can also do genetic studies, but be careful. Not all FH patients that have FH will have a positive genetic result because the mutations are different. There are mutations discovered all the time, and if they haven't been reported, they're not going to know about it. So that's something to keep in mind. Okay, smoker, let's see, CHF, LDL cholesterol greater than or equal to 100 on maximally tolerated statin and Zetia. So if you had one of these and two of these, you were very high risk. And that's where we were in 2018. So this is what I call the toolbox, and it is pretty extensive and thick with a lot of information. I suggest that you use this on your desktop. You can take the slides, there's no copyrights. We're endocrinologists, we don't do copyrights. So, but I do want to give you a rough overview of how these drugs work so you'll know how to use them and what to be careful about. Okay, that's the toolbox. So, I'm going to start off with drugs that regulate the LDL receptor. So let's start with statins. How do statins work? Statins block the biosynthesis of cholesterol, 1. 2, when the cholesterol in a cell drops, that activates what are called transcription factors. And one of the many things that happens as a result of that activation of the transcription factor is the gene that codes for the LDL receptor gets upregulated. So more LDL receptors on the surface, greater LDL receptor density, increased LDL clearance, LDL cholesterol drops. That's how statins work. Okay? No magic, pretty straightforward. We use, and I guess cardiologists have kind of compelled us to do this. We use moderately intense statin, high intensity statin. We're using these as means of defining whether we're getting the best bang for our buck. In other words, if it's a moderately intense statin, let's say pravastatin 20 or 40, or high intensity statin, Crestor 20 to 40, or Lipitor 40 to 80, we want to see a 50% drop from baseline, and a moderately intense statin 30 to 49%. We're going to use this as a litmus test to see if this is holding muster. Because if it's not, the patient still has risk, and then we may need to increase our therapeutic armamentarium and use non-statin pathways, and that's an important point. Another important point that you may or may not be aware of, Southeast Asians and Chinese and Japanese patients, Asians, are very sensitive to statins. So if you start off on Crestor 20 or 40, you're going to have a very unhappy patient. So I would generally start off on the very lowest doses and see them back in 2 weeks, or I did in the day. Right now I do nothing. That doesn't sound good. Okay. So be careful with that. In terms of the range of LDL lowering, it depends on the potency of the statin and the dose of the statin. Okay, and if you like things to memorize, you get the most bang for your buck on the first dose of statin, and every time you double the statin, it's between a 6 and 8% reduction in LDL cholesterol. Okay, and one reason for that is the next point here, that when you lower cholesterol in a cell, that could be an enterocyte, which is in the small bowel where cholesterol is absorbed, or it could be in the liver where cholesterol is absorbed out of the bile, you actually upregulate because the cholesterol pools down, the Niemann-Pick C1 L1 transporter. This is a transporter whose sole job is to basically absorb cholesterol. So if you have low cholesterol in the cell, this transporter gets upregulated and there's more cholesterol being absorbed. So basically, you're boomeranging the statin. So what do? Well, you can get consult as a lipidologist, but I think that's kind of over the top. But what you can do is you can add Zetia. Zetia blocks the Niemann-Pick C1L1 transporter as monotherapy, and we generally don't use it as monotherapy, 13 to 20% reduction in LDL, and as as a conjugate to a statin, you get a 25% reduction in LDL, and it's beneficial, okay? So that's that. In terms of side effects, we know about myopathic symptoms. I personally, and I'm weighing in, I guess because I'm retired, I don't know, I'm a little more bold. I don't believe that arthralgias are byproducts of statins. I think myalgias are, and maybe somehow because their muscles bother their joints work, but all too frequently when I was getting consultations for statin intolerant patients, it was just basic degenerative joint disease and got written off, and the statin that was useful and important, particularly in a high-risk patient, was jettisoned, and that's not a good thing. We also know about new onset diabetes. The hazard ratio is 1.09, so 9% increased risk. When do you see it? Higher dose statins and stronger statins. Okay? So in terms of bempedoic acid, we've already said what it does. It blocks ATP citrate lyase, which blocks acetyl-CoA, and it is very effective on a statin background. Very effective on a statin background. And so in one of the phase 3 trials called the combo trial, the monotherapy was judged in addition to the use of the drug with ezetimibe on a statin background. And the monotherapy reduction was 17% on the statin by itself, but when taken all together, there was a 38% reduction in LDL cholesterol. Now, this was in a trial of 70% of the patients had ASCVD, and baseline LDLs of about 130, and 30% of the patients had diabetes. And still, 1/3 of the patients in the group were on no statins whatsoever because they were statin intolerant. So this drug definitely has a place. In terms of the pro-drug and muscle stuff we've already talked about, and we talked about the secondary prevention trials and primary prevention trials. Okay? Everybody got it so far? Not going too quickly? I just don't want to have you here till 8 o'clock tonight. Okay, so now let's talk about the blockbusters, alirocumab and evolocumab. So why do they both have the same last name? Because they're both fully humanized monoclonal antibodies against PCSK9. Well, why is that important? Because you can form antibodies against antibodies if they're not fully humanized. And that means the drug will be neutralized, or you'll have an attenuation of fat, attenuation of dose response. And so that's why it's important to have a fully humanized monoclonal antibody, at least in this business. So the question now is, what's going on? These drugs basically sequester PCSK9. So how does PCSK9 play into the story? Well, the best way to decide to describe this would be to see what happens if there's no PCSK9 in life. We didn't have it. So basically, the LDL receptor is cleared. The LDL particle is cleared by the LDL receptor. They bind together. They get internalized in a cell. All cells, but let's just for the moment talk about the liver cell. That forms what's called an endosome, and the endosome basically will allow an LDL receptor and an LDL particle to bind with a lysosome, which has got all these suicide enzymes that can wipe out a lot of stuff. But in the absence of PCSK9, the LDL receptor can actually break loose, go recycle to the surface, and every 12 minutes, LDL receptors recycle. And you can say, well, why would we do that? Because it's a heck of a lot easier than getting energy to keep making LDL receptors each time we need them. So that's without PCSK9. Now let's put PCSK9 in the mix. So, for example, the liver makes PCSK9 and it gets processed by endoplasmic reticulum, the Golgi, and then gets secreted into the plasma. And there are LDL receptors floating around, as well as LDL receptors that are on the surface of cells. So the PCSK9 has a great affinity for one portion of the LDL receptor and binds to it. Now, let's go back to what I said before. When this complex is formed, an LDL receptor, an LDL particle, and PCSK9 is like their unwanted relative, and they're all together, the endosome is formed. Well, the endosome has a low pH, and that unfortunately enhances the affinity for PCSK9 and the LDL receptor. So now when the LDL receptor wants to break loose and go to the LDL surface, go to the surface of the cell, it doesn't happen. And so it's stuck, and it gets whopped by the lysosome. And so basically when PCSK9 is around, LDL receptor density drops because LDL catabolism is going up through the roof because of PCSK9. And this was initially found, and this is a long story, but it was initially found when a French doctor at the Necker Hospital found FH kids, a pedigree of kids with very high FH territory LDLs, and didn't have any of the common suspects, the most common being an LDL receptor defect, and ultimately it was found that this was PCSK9 that was causing it. And PCSK9 accounts for about 1.8% of familial hypercholesterolemia, and does exist. And it's basically a gain of function mutation, Okay? So that's how it works. So now we didn't say how the monoclonal antibodies work. The monoclonal antibodies basically got injected into the skin subcutaneously and bind with PCSK9. So I don't know, when I was a kid, I used to watch cowboy movies and we'd head them off at the pass. So basically the monoclonal antibody is going to head the PCSK off at the pass or sequester it so it can't bind with the LDL receptor. And now what you're basically doing is creating a world without PCSK9 and allowing those LDL receptors to recycle, increase the LDL density, increase the LDL clearance, and lower the LDL cholesterol levels. And that's how the PCSK9 inhibitors work, pretty much. Okay, is that clear? Okay, good. I thought about doing that with a picture, but I don't know. I couldn't find my picture. I guess that's why I didn't do it, so I had no other reason. So what is the dose? Alirocumab sub-Q 75 every 2 weeks. In the phase 3 trials on top of a statin background, important point, 45% reduction in LDL on top of what the statins were doing. At 150, this was a long-term trial that went out 52 weeks, 58% reduction in LDL on top of what the statin is doing. Evolocumab, which is Repatha 140, every 2 weeks, 64%, and 420 monthly, 58% on a maximally tolerated statin. The simple way of looking at the indications is that both drugs have the same indication. Basically, the initial indication was for further lowering of LDL in patients that had ASCVD and patients with familial hypercholesterolemia heterozygotes. Now, the Repatha people way back in the day took 30 patients and did a trial with Repatha on homozygous FH and showed a 30% reduction in LDL cholesterol. Keep in mind, these receptors are probably maximum 15% of what a normal receptor is. So to expect that you get mileage out of that was pretty gutsy, but it did work. And so subsequently, alirocumab or Regeneron Sanofi, did the same trial and got beneficial results as well. So they have the same indication. So further LDL lowering for both ASCVD and FH patients, homozygous and heterozygous patients. Both PCSK9 monoclonal antibodies can be used as monotherapy, but they work better. You get more bang for your buck on top of a statin background. Okay? Okay, so the big trials, I mean, these are like big blockbuster trials. The Odyssey Outcomes trial, 18,000 patients, follow-up was, median follow-up was 2.8 years. 48 trial, 27,000 patients. Median follow-up for this was 25 months. These trials look very similar, but they are not. And this is one example where reading the details of the methods is important. Odyssey Outcomes basically said, we're interested in patients that are very hot. These are patients that have an index event within 1 year of randomization. We know if you have acute coronary syndrome, your risk for having recurrent events going out 4 years is 33%. So what happens if we took those patients, if their LDLs were above 70, non-HDL above 100, 30 points higher, and they were on maximally tolerated statin, we gave them probably 75 milligrams sub-Q every 2 weeks, what would be the benefit? That is a very, very high-risk group of patients. So what was the median time from the index event, which invariably was an MI, 90% of them had MIs, or revascularization for MIs? What was the median time from the index event to randomization? 2.6 months. 2.6 months. So they really fulfilled the dictum by getting people that were hot. Now let's look at Fourier. By the way, the prior history of myocardial infarctions in this group of patients was 19%. In the Fourier trial, the prior history of MI was 81%, and the median time from the index event, acute coronary syndrome, or actually a myocardial infarction, it wasn't acute, to randomization was 3.4 years. So really, you know, when you get through all the bluff, the bottom line is these are very hot patients, and this was stable CHD. And these patients were on statins for a long time and felt very comfortable. That said, in the Odyssey Outcomes trial, by the way, both had an LDL cholesterol of 92 milligrams per deciliter. In the Odyssey Outcomes trial, 89% were on high-intensity statins background, and Fourier was 70% background. So the primary endpoints were, myocardial infarction, CVA, cardiovascular mortality, hospitalization for unstable angina. Notice it did not include revascularization. Here it did. And again, the reason is because some people believe revascularization is discretionary and not a hard endpoint. So basically, this was a 15% reduction. The secondary endpoint would involve 15 minutes of discussion. I really don't want to go into that, so I'm just going to keep it here. Interestingly, the baseline LDL, in other words, there were 3 tertiles. LDL is less than 80, LDL is 80 to 100, and LDL is greater than 100 milligram per deciliter. The baseline tertile in Odyssey outcomes had the highest incidence in the primary endpoint and also the greatest benefit in the primary endpoint. Interestingly, post hoc analysis, which you could say is hokum and statistical, not valid, but it turned out it was valid. There was a 20% reduction in all-cause mortality in those patients whose LDL cholesterol was greater than 100 milligram per deciliter. So if we look at the 4A trial, here the endpoints are the same, plus cardiac revascularization, 15% endpoint in the primary endpoint, and the secondary endpoint. I call it the 4A triad, which is non-fatal MI cardiovascular mortality and non-fatal stroke. So both of them were very effective. And by the way, baseline LDL did not play a role whatsoever in the impact on the primary endpoint in 4A. So different patient groups. And it's important to understand that because if you read through it and you read reviews, you don't really get that point. But it's a very important distinction to make. Okay? Nobody confused? Okay. If you get confused, stand up and say stop. Okay, so we've now realized that the monoclonal antibodies basically work on the finished product of PCSK9, right? They inactivate it, they sequester it. So now let's talk about inclisiran, which basically works on the production of PCSK9. And I believe I have a slide. Yeah. Good, so this is inclisiran, and I got to tiptoe through the tulips here because Dr. Bao is an expert on molecular biology, and I am a neophyte, so let me just start from that. So inclisiran is double-stranded RNA, okay? Now, my understanding is cells do not like or are used to double-stranded RNA. So the blue is the guide strand. The guide strand is complementary to PCSK9, and it's going to take this complex to the PCSK9 messenger RNA. Once this hits the liver cell, RNA-induced silencing complex, also known as RISC, gets activated, and this is going to chew up RNA. And so the passenger strand is now jettisoned. The RISC enzyme is tethered to the antisense or the complementary strand to the PCSK9, and then basically the RISC does its bit and just chops up PCSK9. So PCSK9 does not get made. The gene is transcribed, but there's no translation because the messenger never makes it to the ribosome because it's chopped into little pieces. And that's how the drugs work. So basically, inclisiran blocks production, whereas the monoclonal antibodies block the finished product. It's a simple way of looking at it. Okay? Good. Let me go backwards. So the LDL lowering is 48 to 52%. Inclisiran is given typically at 284 times 1 subcutaneously, and then every 3 months and 6 months. And it's got the same indications as PCSK9, with the exception of homozygous FH. So it's for further LDL lowering in ASCVD patients and FH heterozygous patients. They used different dosage schemes. Day 1, day 90, 270, 450, and it was difficult to follow what the LDL cholesterol would be unless you broke this into 2 intervals. And the other thing they did is they measured peaks and troughs of drug, because they didn't really know what they were dealing with. And the peaks and troughs were at 120-day intervals, alternating with 60-day intervals. And so the bottom line is they just decided we're going to look at 2 endpoints. One is the percentage change in LDL from baseline to day 510. Well, the study ended at day 540. Why did they choose 510? Because that was totally consistent with the peak and trough measurements they were making. So they got 2 for 1. And second of all, they looked at the time-adjusted percentage change from baseline, and that was from day 90 to day 540. Notice these numbers are pretty similar. They didn't know that at the time. This was kind of like, let's see what we're going to get. And so basically, those are the 2 endpoints in terms of the LDL reduction. The FH, the Orion trial was FH, familial hypercholesterolemia, heterozygotes, and they used 300 milligrams as opposed to 284. Baseline LDL was 153, and that was on a statin background. So now if we go to the studies, Orion 10 was basically an ASCVD trial. Orion 11 was an ASCVD risk equivalent. So an ASCVD risk equivalent was a patient that had type 2 diabetes where the Framingham risk score was greater than or equal to 20% for 10 years, or a high-risk patient, and this was on a statin background. So Orion 10 lowering was 52% from day 1 to 510. Orion 11 for day 1 to 510 was 50%. Similar, still in that bracket, so I'm not lying about these numbers. And then finally, if you look at the placebo-adjusted for Orion 10, it was 54%, not placebo-adjusted, excuse me, the time-adjusted, but they were placebo-adjusted as well. The LDL cholesterol lowering was 54%, and Orion 11, the LDL lowering was 49%. So the numbers clustered pretty well. Let me say that there is no mechanistic reason to use inclisiran and a PCSK9 monoclonal antibody together. None whatsoever, even though one blocks the production and the other blocks the action. But you should not use them. Okay, so now let's talk about ezetimibe. Ezetimibe, we know, is used at 10 milligrams daily. It is blocking the Niemann-Pick C1L1 transporter and therefore lowers LDL cholesterol because there's less cholesterol absorption, and then the LDL receptor gets upregulated because there's less cholesterol in the cell. It's really always the same story. If we use it as monotherapy, it's 13 to 20%. If we use it on a statin, it's about 25%. And one very quick pointer of reference, you will see very rarely, but you will see patients on Zetia monotherapy, their LDL cholesterols will drop by 36%. They have a variant in the Niemann-Pick C1L1 transporter, and Zetia will basically kick the butt out of it, and then the LDLs will drop, and it's for real. So when you see it, it's a blessing. So don't say, well, it's a lamp arrow. It does happen. Okay, so the proven trial, by the way, rapamyelitis does happen, but not commonly. So if a patient comes in and says, I can't lift my arms, don't blow it off. It's something that really needs to be evaluated. Get a CK, get BUN, creatinine, etc., and do a good physical exam and see if they can stand up out of a chair. Okay? This is in the package insert that does occur. Okay, so the IMPROVER trial. The IMPROVER trial is very controversial. For the longest time, cardiologists believed that Zetia was a non-drug and believed that it was a bunch of hooey and didn't think it was effective. And they said there are no trials. So then we said, well, there's an IMPROVER trial. So the IMPROVER trial basically tested two questions, or posed two questions. The first question is, if we get LDL levels really low, and the on-trial LDL for placebo was 69, and the on-trial LDL for the treated group was 54. But we're taking patients with acute coronary syndromes, high. So they're basically randomized within 10 days of acute coronary syndromes, and they're either going to get Simba 40 and ezetimibe 10, or Simba 40 and placebo. So they were not only asking what happens when we get LDL levels very low, but would a non-statin pathway, a non-statin drug like ezetimibe, have the audacity to be able to lower cardiovascular risk any further? And so those were very valid questions, and there were many cardiologists, most of whom told me that this was a ridiculous drug, basically said, don't do it. So the result was that the placebo group, the endpoints are here, they were basically pretty typical endpoints, cardiovascular death. The only thing that was interesting that was if they had revascularization, it had to be 1 month after the surgery, after the acute event. Okay? So as I said, the LDL was 54 in the treated group and 69 in the placebo group. So let's just play a game for a sec. If you remember the cholesterol treatment trialists, 38.6 milligrams per deciliter. So let's take a difference of 69 and 54 is 15, multiply it times 3. So that's like 45. 45 is close to 38.6. So let's call that a 1 millimole per liter drop. Okay? So now let's look at the hazard ratio is 0.936. So basically it's about a 6.5% risk reduction. Multiply that times 3, that's about 20+%. So what we're seeing in the wild, or in a randomized clinical trial, was the prediction that the cholesterol treatment trialist was correct. A 1 millimole per liter, 38.6 milligram per deciliter, produced a 22% risk. And for those people said, well, if this caps out, you go too low, you're not going to see any benefit. 69 versus 54 is pretty darn low, and still there was a cardiovascular dividend. Sadly, this drug was not approved for, and I have I have no connection with ezetimibe, but sadly it was not approved for further lowering of LDL and reducing coronary risk. And I think the reason for that was there were 27% of the patients were diabetic, and they had a 14% reduction in the event rate. And it's very possible that this was thought to be a subgroup benefit, and that the FDA didn't want to stick its neck out and say, well, we're going to use this for everybody. That's my speculation, but I don't know if it's true. So bile acid sequestrants, okay? I mean, most of us don't use them. In fact, way back when in the lipid research clinic, when these drugs first came out, at year one, I think the number of people that were not even taking the drug properly, but just taking it anyway, was like 10%, because they had all these god-awful GI side effects. But what is the mechanism? Because that's what really drives my thinking in all this stuff. The mechanism is the liver basically makes bile acids, and bile acids help facilitate absorption, and it ends up in the duodenum, blah, 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 blah. So normally the bile acids are reabsorbed by the enterohepatic cycle and get picked up by the liver. But with bile acid sequestrants, they get stuck. They can't. So the point that's really of interest is cholesterol is a precursor to bile acids. And that enzyme is called 7-alpha hydroxylase. It's a detail, but nonetheless, that's what happens. So when bile acids drop, a transcription factor called farnesyl gets upregulated, and that basically moves the 7-alpha hydroxylase to be activated, and now cholesterol is being diverted to bile acids, and guess what? Cholesterol level drops, that upregulates a transcription factor, that upregulates the LDL receptor clearance goes up, LDL clearance goes up, and LDL cholesterol goes down. Really simple, It's nice when you know how it works. You don't have to memorize anything. So if you use it, and I'm pretty sure I never spelled clobesterol the same in 2 slides, so I'm not sure which one is right. But anyway, 15% lowering in LDL, that's by itself as monotherapy, and as if it's used on top of a low or moderately intense statin, you get another 15%, so about a 30% reduction. Now, I did mention kind of a dirty word, and I mentioned farnesyl, the transcription factor. If you have a patient with a triglyceride level of 300 milligram per deciliter or higher, do not use these drugs. And the reason is, so it's nice to know the reason, farnesyl, in addition to what it does in terms of enhancing bile acid concentration and synthesis, it also stimulates de novo lipogenesis, which is basically making fatty acids. So if you start off with a triglyceride that's 300, your fatty acid is going to be made because you're turning on this transcription factor that basically is going to turn on synthetic enzymes for fatty acids. Your triglycerides can go through the roof, and so 300 should be your cut point. Be careful, you can get burned, particularly in diabetics, because the average diabetic has a triglyceride probably about 250. So that's a problem. Okay, one last thing. The bile acid sequestrants do have some benefit in terms of diabetes, presumably by diminishing postprandial hyperglycemia, by retarding the absorption of glucose. That's at least the thought. It's not a major benefit, but it is some extra bang for your buck, so you get 2 for 1. You can either take it as 6 tablets for a total dose of 3.75 or 3 tablets 1 hour after breakfast, 1 hour after supper. Why after meals? I was asked, why after meals? Because that's when bile acids get secreted. Okay, so now we're starting to get to the meat of the matter after all this sort of intellectual foreplay here. We're going to look at 4 groups for whom the non-statin pathway is indicated. So the first is secondary intervention, and then is primary prevention. These are adults with primary severe hypercholesterolemia. So if you look at the NHANES data, there's about 18% of males above the age of 21 that have LDLs of 190. But if you look at genetic studies, only 1.6% of those by genetic testing have familial hypercholesterolemia heterozygote. So, and to make matters even worse, there's a polygenic form of familial hypercholesterolemia, which means that it's very hard to trace in the family because it's not one major allele that's wrong, and if one parent has it, you have a 50% chance of getting it, and you'll see it in nuclear families. So anyway, we're going to look at that. We're going to look at diabetes and patients without diabetes. So one of the things that I think cardiologists do better than endocrinologists is they know how to get the bang for their buck. So basically, they want to evaluate the use of a statin by two criteria. Number one, they want to see an LDL cholesterol drop by a certain amount, a certain percentage, which I have never used until I started looking into this. And number two, they want to reach an LDL cholesterol value, which they call a threshold, and the LDL cholesterol drop from baseline is also called a threshold. And the reason for that is in randomized clinical trials, if the numbers reached on the trial were above this threshold value, for example, for LDL cholesterol and 30 points higher for non-HDL cholesterol, there was less benefit than if it were lower. And they don't want to use the term goals, I don't know why, but so these are called thresholds. So in order for a statin to reach, to be effective, or judged to be effective, before you make a change in drug in these patient populations, number one, you want to reach the threshold of LDL dropping, and we'll discuss what that is. And number two, you want to reach the LDL absolute value, cholesterol and non-HDL cholesterol. So which intensity statin you use, that's a function of the patient population. I've already said that the absolute arterial LDL value is a therapeutic threshold. So when I call them therapeutic thresholds, I'm using the verbiage that comes right out of the Bible, if you will. Okay. Now, if these are not reached, then you would think about going to a high intensity, then you would think about going to a non-statin pathway and other drugs that we might not normally use. Now, for just, it's nice to have these rules on the front end, because otherwise you can get lost in arrows and you feel like you're in the New York subway and you've never been to New York before, so I don't want that to happen. So for ACVD, the LDL cholesterol, absolute LDL cholesterol is less than, and that's wrong, it's less than 55 milligram per deciliter, and non-HDL is 30 points higher, less than 85. That's number one in the ASCVD group. For anyone who's got a baseline LDL cholesterol on ASCVD and has FH data that's supportive, that means clinical data or genetic test, those people, and their LDLs are greater than 190, should have an LDL that is less than 55 milligram per deciliter, non-HDL less than 85. All other ASCVD patients, the LDL cholesterol should be less than 70, non-HDL less than 100, and all ASCVD patients should have an LDL cholesterol drop from baseline of greater than or equal to 50%. So if you remember that, or just go over that, then when you go through all these algorithms, you won't get a headache, and you'll have some knowledge. For primary prevention, and again, it's making the distinction to have lower risk. I'm not so sure that that's true. And the bempedoic acid study basically makes me feel that way. But LDL cholesterol less than 100 as the absolute value, non-HDL less than 130, and an LDL cholesterol drop from baseline for a moderately intense statin is less than 30 to 49%. And so again, this is just a lot of blah, 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 but if you go to the different colors, that if you do not reach these therapeutic objectives, for want of a better word, consult the non-statin pathway. And we're going to go through them real quickly, and a lot of the stuff you're not going to see, but at least you'll recognize, oh my God, this is somebody that needs to be referred. Okay, and that's an important point. I have utmost respect for primary care doctors because I don't know how they do it all. You know, it takes a long time to be able to master all that stuff. Okay, so these are the 9 different pathways, 9 different patients. We'll go through them one by one. This is just reiterating what I said before, just in bigger font. I think I think I forgot that I did this slide before, but I decided to put it again because it is important. And notice, I'm a big person with color, so if all these things are blue, that makes it easier for me to remember that all these things have to be dropped by 50%, and the red also tells me that that's where these absolute thresholds need to be. Okay? So, it's okay. Okay, so again, I don't like looking at maps. You know, I think I have dysfunctional dysphagia or something. Or ADD. So what I did was, instead of taking these algorithms and write yes, no, yes, no, yes, no, with arrows all over the place, I think that that would confuse the heck out of anybody. So what I did was I said, I'm going to just go through that each step along the way is no. We didn't reach the therapeutic threshold. And then I'm also, notice at the bottom here, I put dot, 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 dot. That means the answer is yes, we'll just continue on the pathway and not make any changes. So this way, if you have that, you don't have to worry about 15 million arrows and forget the algorithms and what the hell is he talking about. So we're going to start here. ACVD, very high risk. Again, we're starting with the assumption greater than 50%. Notice any in this group that need a 50% drop LDL, LDL less than 55, non-HDL less than 85, maximum tolerated statin. Answer is no. So step one, what do we do? Therapeutic lifestyle change. That's diet, and I'm a big fan of diet. I think it's very, very important. I use a lot of fiber, and I cut back on saturated fat to less than 3 to 5%. Is the patient taking the drug? I mean, that's always a good question to ask. And number 3, are there statin intolerant side effects? So a maximum tolerated statin, if we do not reach this therapeutic objective, next is a high intensity statin. And this will get very repetitive, so you could probably get the talk. So here at result 1, we didn't reach it. We now go to the non-statin agents. We use ezetimibe and or PCSK9. Now these are very high-risk patients. If they're having progressive events, then you're going to use both drugs together. There's nothing sacred about saying, well, you got to do this first or this first. I mean, I can give you conditions, but it'll just be confusing. So that's the first step. If we still don't reach this, now we use bempedoic and inclisiran. But of course, bempedoic acid came out, that data came out after this algorithm was built, so they didn't have outcome data. And inclisiran doesn't have any outcomes data. They won't come out until 2026, 2024, and 2026. And you know, empirical-based medicine means basically you have to show me the data. So that's why that was in the second place. And if we still don't reach it, refer to the lipid specialist. And again, I'm pain and being repetitive. If any one of these was yes, we would stop and just continue to monitor the LDL until which point it was no longer working and we had to change horses. Okay, let's go to the next one. This is not very high risk. Notice the LDL drop is always got to be 50%. Now the LDL is less than 70, non-HDL less than 100, maximum tolerated statin. We don't reach it, so basically we go to a high intensity statin. So the answer is no, we don't reach where we need to be. Now we're back in the statin pathway. But because these are not very high-risk patients, we would use ezetimibe, okay, as our first hit. If ezetimibe were not effective, and this were not reached or this were not reached, we would need both to be reached. Then we could either use PCSK9 in lieu of ezetimibe, or we could replace the ezetimibe with PCSK9, and that's up to the discretion of the provider. If we still didn't reach it, bempedoic acid and inclisiran, and very importantly, I think I said this before, as you get older, you forget stuff, so inclisiran should not be used with PCSK9, it should supplant PCSK9, I think we got that. And finally, if we didn't reach it, we would refer to a lipid specialist, which is useful, because a lot of times, I once get to talk to vascular surgeons, well, when do I refer you? And I never really thought about it. And so now it is an important thing because you want to get it to the right doctor. So here we now have a different bottom line, ASCVD again, LDL greater than 190, so this could be FH, but no clinical evidence. The Dutch criteria, the Simon-Broom criteria, negative, and no genetic support. So what do we do? So first of all, we want the LDL dropping by greater than 50% as everyone in the ASCVD group, but the LDL less than 70, non-HDL less than 100, maximally tolerated statin. Now, we do everything we've done so far the same, but we, therapeutic lifestyle change, adherence, go to a high-intensity statin. But now we may be dealing with a FH patient. We don't know. And if there's any concern for that, do not pass go, call for the lipid specialist, because that patient needs to be evaluated immediately, okay? This is kind of DKA of atherosclerosis, if you will. So in any event, result 1, no benefit. Now we would use ezetimibe or PCSK9. I'll probably use them together. If not, if we didn't reach the therapeutic threshold, and I'm mincing my words, bempedoic acid and inclisiran, and we still didn't reach it, LDL apheresis. So LDL apheresis is literally taking tubes and drawing blood, plasma actually, from the patient's body, ex corpore, from the body, from Latin, and going through either a dextran filter or a heparan sulfate filter. Now, I am not the best person in the summertime to clean my filters for my air conditioning, but I do know that when I do that in September and I put it in June, it is gray and goopy and disgusting. Well, now imagine that being yellow and orange, and in someone, that's what the filters look like when these people get freezed. It is just frightening that this is what's circulating into the bloodstream. And I give you that analogy not to be gross, but just to give you some feeling about what these people live with on a daily basis. So in any event, so that is basically Here, LDL apheresis, obviously you're not going to do that by yourself, and you get a specialist, and if you didn't reach it, we would refer to a specialist anyway. Okay? Good. I mean, is this working? Is this making sense to you? Good. Excellent. Now we have this very same condition, however, we do have clinical diagnosis. The sign improvement criteria are positive, or the Dutch criteria are positive, score is 8 or higher, or the genetics testing is positive. So here again, we're going to get, if this is not reached, we're going to get a specialist to evaluate for homozygous FH patients, because that's over the top for somebody who does not have the experience. Again, LDL needs to drop by greater than 50%, less than 55 or less than 85 if we didn't reach that. Ezetimibe or PCSK9. 2, if we didn't reach bempedoic and inclisiran. 3, even acumab, lamidopide, or LDL apheresis. So I threw a monkey wrench in there. So apheresis we've already talked about, right? We get that, and that's a big deal. So even acumab, and this is going to take a little bit, even acumab is a monoclonal antibody from the QMAB, and it is a monoclonal antibody that basically blocks angiopoietin-like factor 3. And if there's anybody, have any of you guys heard of that? So let me cut to the chase. ANGPTL3 is an inhibitor of lipoprotein lipase. Lipoprotein lipase is an incredibly important enzyme for how we handle fat. And so VLDL particles get metabolized by lipoprotein lipase, and then go to remnants, and then they go to intermediate density lipoproteins and then LDL. So the key is, let's say we have a homozygous FH patient, the LDL receptor is not going to work, so that LDL is just going to hang around. But since LDLs are begotten from precursors, VLDL particles, and if we're now inhibiting the enzyme, inhibiting the inhibitor of the enzyme, we're now basically moving the pathway much quicker, and so the LDL particles go down. And so Frederick Raleigh, who is from South Africa, published in the New England Journal, 35 patients with FH above the age of 12, of which 35% of them were on apheresis, and gave even acumab at a dose of 15 milligrams per kilogram per month. And these were patients that had really bad LDL receptors or bad LDL receptors. It was 15% was the cut point. And he found that at 1 month's time, the LDL cholesterol dropped by 45% and stayed low so long as I got the 15 milligram per kilogram IV injection. And so now even acumab has the indication for FH homozygous treatment, which is a big change from where we were before. Lamidopide basically is important for the formation of a nascent VLDL particle, which is the first particle to get out of the liver. And by blocking an enzyme called microsomal triglyceride transfer protein, you're basically not allowing the formation of that VLDL particle. So there's no precursors for LDL, so there's no LDL, basically. And so that's the way that drug works. The problem is, and I'm sorry that Dr. Antowako's not here, the liver is now trapped with all this fat in it, and liver enzymes can go through the roof, and you gotta be really careful because you can cause real major problems with transaminitis because of the fat in the liver, not to mention insulin resistance and all the other stuff this we talked about. And apheresis we talked about. So that's basically it. So now let's just talk about primary prevention. Primary prevention, by the way, another thing, factoid you might want to keep in your head is that if if the baseline LDL is greater than 190, then you should try to use a statin that will lower LDL by 50%, at least. That's what you want. So this is primary prevention, and in primary prevention, the LDL cholesterol objective threshold is less than 100, non-HDL is less than 130. So it's a little different because this patient population has different risk. So basically, you go through what we said before, with those cut points, with those thresholds rather. If we had therapeutic lifestyle change was not helping against statin, we would go to the high-intensity statin, we would try to reach that endpoint. If that didn't work, non-statin drug, ezetimibe or PCSK9, dropped by 50%. If that didn't work, bempedoic acid or inclisiran. And now, because this could very well be FH, we would use even acumab, lamidopide, and LDL-pheresis, which I think at least you're familiar with what the rationale is for using those drugs, because they're independent of the LDL receptor. And finally, if we didn't reach the therapeutic objective here, we would basically refer to a lipid specialist, but chances are you would have done that way up here. Okay? So now let's go to the primary prevention, or pooled cohort equations and risk enhancers. So pooled cohort equations basically are a way of looking at cohorts, looking at a number of covariates, systolic blood pressure, HDL, smoking, age, etc., and then correlating that with observed events, cardiovascular events in various populations. And then they get some real smart statistician to basically write out the best fit between the x-axis and the y-axis. And that could be logarithmic, it could be curvilinear, it could be linear, etc. So anyway, this is basically used, Framingham does not have any African Americans in it. And Framingham goes back to 1948. And so we don't, Framingham basically should not be evaluating African Americans. And Framingham also, when initially introduced, basically only looked at CHD, whereas pooled cohort equations looks at African Americans and stroke. That's the difference. And we should look at what those numbers are, what the 10-year risk is, to stratify risk, and that defines algorithms. So basically this is 2019 ACCHA guidelines. We only do this in ages 40 to 75, and we're interested in borderline and intermediate risk. And the reason is because this is incredibly heterogeneous, and we need better filters to figure out who to treat and who not to treat. We do not use pooled cohort equations in young people. It has no value. We don't use pooled cohort equations in people with FH because they've been exposed to LDL all their lives, and we know that their risk is very high. So this is the clinical enhancers. You'll see it in the slides. I'm not going to read through everything, but I am going to make one point, and that is we forget, and I think maybe it's a male problem, I don't know, probably a provider problem. We forget that women that have problems with pregnancy have a greater risk for ASCVD. And the reason we forget that is because pregnancy is a vascular stress test. So if a woman has a small progestational age, and that's the result of placental insufficiency, I mean, that woman has a higher risk of ASCVD years down the pike, and that needs to be recorded. And I can tell you, I don't always do it. And then, of course, if they have preeclampsia, same thing. And finally, if a woman has premature menopause, since estrogen protects them, and the estrogen goes by the wayside, either because FSH is causing resistance, there's resistance to, the follicles are resistant to FSH, or because there's destruction of the follicles, whatever the reason, on an autoimmune process, the bottom line is those people have a higher risk, etc. And then there are laboratory enhancers, and if you go through the slides, you will see what those things are, and you can use that to further assess risk. Okay, so basically here's the risk. Borderline and intermediate risk patients right here. If the risk enhancers are positive, then we would basically use a moderately intense statin with that objective, and if we didn't reach it, a high-intensity statin. In this group of patients, these patients very often have event rates that are higher than ASCVD patients. So we would start with a high-intensity statin. We didn't reach where we wanted to get to. We would then use ezetimibe, and that would be the pathway that we would follow. But you'd have to be a high-risk patient and not have a therapeutic threshold reaching objective. So what about diabetes? It's a very similar algorithm. So every diabetic should be at least on a moderately intense statin, but we now use the calculate the 10-year PCU risk and risk enhancers to determine whether we should uptick that. So if result 1A is anyone who has an anyone who has a 10-year risk greater than 75%, enhancers, or subclinical atherosclerosis, we immediately go to a high-intensity statin. If the answer was no, we'd stay on a moderately intense statin, and if they didn't reach that threshold, we would then go to the high-intensity statin. Alternatively, if we had a 10-year risk of 20%, then what we would do is go to a high-intensity statin, but if we didn't reach that therapeutic objective threshold, we would go to ezetimibe as well. And that's how that pathway works, okay? So PCE is essential for primary prevention, and risk enhancers are. So what about calcium scores? First of all, the most important point is that calcium scores only look at calcified plaque. They do not look at low attenuation plaque, which is what causes disease. Calcium score of 0, it's reasonable to do nothing, but if the patient has diabetes or high LDL, I would treat with a statin and work up FH. If the calcium score is 1 to 99, and this percentile is less than 75, a moderately intense statin is reasonable, and if we didn't reach the therapeutic objective, increase to a high-intensity statin. Keep in mind, calcium scores are biological properties, so we need to look at what the percentile is for age, sex, and race. And the people that have the lowest calcium scores are Asian men. The calcium score is greater than 100. It's malpractice not to treat this person, and that person should be given a high-intensity statin. In my opinion, they suggest a moderate or a high-intensity statin. And if we don't reach the threshold, then ezetimibe. And calcium score greater than 1,000, we don't even put a percentile because it's off the charts. I had a patient like that, sent her to a cardiologist, did a stress test, it was horrible, had a cath and triple vessel disease, and got bypassed. Just from this. So keep in mind, subclinical atherosclerosis is a disease. It just hasn't surfaced yet. And so we want to intervene before that causes problems. Okay, we're almost at the end. Deep breath. Okay, so statin intolerance. So the definition of statin intolerance is 2 statins with one try at the lowest statin or at alternate days of therapy rather than taking it on a daily basis. So the way to look at this is very simple. These patients are not tolerating statins. So anyone whose LDL is 190, whether it be secondary intervention or primary prevention, is a 3-step move. Number 1, PCSK9 ezetimibe, 2, bempedoic inclisiran, and 3, evenacumab, which at least you're familiar with. And the same thing is true for this pathway, even though they don't have ASCVD. It's exactly the same. For not very high risk, it's twofold risk, twofold pattern, ezetimibe or PCSK9, or bempedoic acid or inclisiran. For diabetes or non-diabetes, it's the same pathway. Number 1 is ezetimibe, number 2 bile acid sequestrant. However, if the triglycerides are high, wouldn't do that. And number 3, bempedoic acid. So, conclusions, what have we learned? Hopefully we learned a lot. And we've learned that 1 millimole per liter reduction in LDL cholesterol produces a 22% risk reduction. We've learned that that phenomenon is not attenuated or changed by patients that have low risk or high risk disease, at least as evidence from that study that was done in Britain. A baseline ASCVD risk does not impact on the 1 millimole per liter reduction on events. We've also realized that in primary and secondary intervention, the lower the on-trial LDL cholesterol, the lower the hazard ratio. And keep in mind, the lowest value reached in the Buchholz meta-analysis was less than 50, and the hazard ratio was 0.44, or 7% lower from the bottom, and that was not used for some reason. Bempedoic acid works, primary and secondary intervention, no doubt. The question is, what happens if we do a study in primary prevention, but we don't have 66% diabetics? Would those numbers be the same? And I don't know the answer. The statin efficacy is not reached, and we know that has to do with baseline LDL dropping, as well as the LDL threshold, absolute value of non-HDL. These are the patients that we would treat, and that will be in the slide. All ASCVD patients, you want to see a 50% drop in LDL, and then patients that are very high risk, basically, and then patients that have an LDL gradient between 90 and evidence of FH, then we want to see that number less than 55 or less than 85 for the genetic proof. All other patients, LDL thresholds less than 70 and non-HDL less than 100. Primary prevention, pool-card equations. The risk enhancers, if you have a color-coordinated computer, which I think I have, E is ethnic, Southeast Asia, F is family history, G is gender, H is for HIV or inflammation, K is kidney disease, L is lab, M is metabolic syndrome. So you can just go down that, and if you do that a couple times, you'll remember it, you won't have to study it. And finally, the heterogeneous group that we're worried about are those that are borderline or high risk. And the hardest patient to evaluate is a young person, less than 45 years of age, who has a calcium score of 0 and an LDL of 160 or 170. What do? Do you just stop because the calcium score is 0? I would argue no, because they can have a low attenuation plaque, which can rupture, and you don't want to miss FH, and those people need to be evaluated. Work up for FH, there was like a Simon-Bloom criteria. So, everybody still here? Probably somewhat bored. So the 3 Bs, I hope I was thorough, I hope I was courteous, and now I will be seated. Thank you for your attention. I appreciate it. Thank you.